Thank you very much for the Dr. Fatima and all organizing committee that invited me for this interesting scientific meeting in Dhaka in Bangladesh. I'm very honored about this. So my presentation is focused mainly on the infection endocarditis and left ventricular masses, but I will try to be very short about this big topic, so I don't have any disclosure about this presentation. I'm starting with one question about what is about your opinion. How is very often is the infection endocarditis in contemporary Western cohorts? 1 to 7 per 10, 100,000 person per year, 50, 70, or 5 to 7 of the 1,000 person per year, or 5 to 7,000 person per years. Actually, this is the very old inflammation disease, which is the first mentioned from the Professor Osler in 1885 about the inflammation, which located generally of the flow site of the valves, or located of the endocardial damaged area of the image of the heart. Sorry. Like epidemiology, we can find that annually incidence of the endocarditis is around 5 to 7% per 100,000 people of the location. So it's very uncommon disease, but it's associated with a significant morbidity and mortality. And this is the one of the third of the life-threatening infection after the sepsis and pneumonia and the human life. So it's mainly predominated of the male than females. It's around 2 point per 1, and age is which is onset this disease is over the 60 per man of the older than a woman. It's very uncommon for the children, but it's occur when it's treated for the congenital heart disease. The mitral valve is very often involved in this disease. When we have the diagnosis about the infective endocarditis, we are looking about the major and the minor criteria, which is very important. When we have this positive blood culture from the typical organism, persistent the positive blood culture for any organism, single positive blood culture for the corneti, and echocardiography positive signs for the infective endocarditis. There is also the minor criteria, which is the predisposition for the heart condition of the infective valve disease, high fever than 38 degrees, and vascular phenomena like arterial embolism, septic pulmonary infarction, mycotic aneurysm, genuine lesion, and microbiological evidence that doesn't meet like the measure criteria. Also, the positive blood culture, it would not meet the major criteria, and some of the immunologic phenomena about this disease. When we look at the echocardiography, the criteria, we're using these new criteria, which is must have the positive echocardiogram, oscillating intracardiac mass, or absence of or new partial dehiscensis of the prosthetic valve, or new valvular regurgitation. This is the one very nice case, which is endocarditis, which is involved the mitral valve, and this is a 3D echo of this huge vegetation that we could find during the echo examination. Diagnosis of the clinical criteria is definitely we have the disease of the infective endocarditis when we have 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. It's possible to have infective endocarditis when we have 1 major criteria, 1 minor, or 3 minor criteria. And we rejected the diagnosis when we don't have any alternative diagnosis. We don't have the resolution of the syndromes less than 4 days, no pathological evidence of the infective endocarditis after antibiotic treatment for less than 4 days. Echo feature of the vegetation. This is the echogenic mobile mass, which is located mainly on the atrial side of the mitral valve, ventricular side of the aortic valve. It's very shaggy, irregular. More of the time is amorphous. Intermediate echogenicity we can find look like the myocardium. The motions is very independent of the valve. This is oscillating and very often is associated with the tissue deformation and destruction of the valves also. Then we have the risk factor, which is connected more often with this disease. Most of the time, we could find the previously dental treatment, congenital heart disease, unusual heart murmur, rheumatic fever, mitral valve prolapses, and cardiac valve surgery. Who is need from the prophylaxis of the endocarditis? When we have actually prior infection of endocarditis, when we have the patient with the prosthetic valves, we must include this prosthetic with the prosthetic material when we use the valve repair. Patient with the congenital heart disease and valvulopativa after cardiac transplantation. This group of the patients, they definitely need prophylaxis from the infective endocarditis. Imaging of the infective endocarditis is very important, and when we have this cardiac examination with the ECG echo, cardiac CT, PET CT and cardiac MRI, more often we can find the vegetation, but the echocardiography, mainly transthoracic and transesophageal, this is the main and very useful and very easy to perform for the bedside of the patient. The goal is actually to assess the cardiac structure and function, assess the periannular anatomy, assess the conduction system function, and the coronary anatomy. Non-cardiac examination is included the CT, MRI, which main goal is actually to assess the mycotic aneurysm, the sources of the stroke, in intra-abdominal pathology if we could find from the diagnosis. The sensitivity of the echocardiography as method for the analyzing the infective endocarditis is around 30% for prosthetic valves when we have transthoracic echocardiography, but transesophageal echocardiography is around 95 to 100%, or roughly around 90% for the prosthetic valves. Very specific, good for the both examination. Sources of echo on error in echo interpretation, it's mainly when we don't have the good window for the good quality of imaging. Valvular degeneration, which could analyze the calcification, sclerosis like vegetation, and other masses like the papilloma, thrombus, myxomatosis, degeneration of the valve, healed old vegetation, small sites of the vegetation, and overzealous interpretation of the echo. When we look at about the patients with infective endocarditis with the transesophageal echocardiography, this is the main that we could exclude to the diagnosis. This is one of the highest sensitivity of the days when we have the symptoms of the fever. It's like the 5 to 7 days of the beginning of the symptoms, but if no other metastatic foci of the antibiotic course will be around the 14 days of the examination. Transesophageal echocardiography must be repeated on the end of the second week of the course of the antibiotic treatment prior to completing antibiotics. Around 10 or 15% of the population, we don't have any development in infective endocarditis. Another group which is very not often conclusion with the infective endocarditis this is the pregnant woman, but the outcomes is very difficult to analyze it, and this is the one of the maternal morbidity and mortality with a high risk. Around this we could find, this is the left side engaged endocarditis and less on the right side. We could find the septotic pulmonary embolism, which is around 20 to 25% of this in this group. And the central nervous system embolism is very often in the pregnant woman. The fetal outcomes is connected with the delivery and the survival about the discharge around the 50% of the in the woman with the endocarditis. Intrauterine demise is around 10 to 15%. Echo predictors of the systemic embolism with the patients with the endocarditis, it's when we have the visible vegetation by both transthoracal and transesophageal echocardiography is more often. We could find the abscess of the formation, high mobility vegetation. And especially when we have the vegetation sites more than 10 to 15 millimeter. Vegetation more than 50 millimeters is very independent predictor of date. High mobile vegetation also with more than 50 millimeters is considered with the early surgical intervention. It's like the guidelines. We have the recurrent embolism, which is very persistent with the vegetation. It's also indication for the surgery. Mitral valve endocarditis, particularly on the arterial leaflet, is very often for the systemic embolism and also biventricular vegetation. We can see that the sources with the vegetation sites more than 15%, 15 millimeters, it's with the high risk of the embolic events, and when we have the more vegetation than one leaflet or the one vegetation, there is also a high severity of the risk of the embolism. This is one of the study which is looking about the vegetation sites. It's included around 150 patients with the endocarditis, about the aortic on the mitral valve. The stroke occurred more often in the mitral valve endocarditis. It's around 33% than aortic valve. Independent predictor of the stroke, the study find that mitral valve vegetation length more than 7 millimeter is with the high risk of the embolism. Predictors for the 1 year mortality of the another study is around conducted again with the vegetation length more than 15 millimeters. The moderate of severe chronic heart failure is around with the high risk of the 1 year of the mortality. Female sex also is included with the higher mortality, and comorbidity more than 2 index. It's also with the high risk for the mortality. Early surgery from the infective endocarditis with the large vegetation. It's another study which is published several years ago. They look at about the early sending of the conventional treatment than the conventional treatment of the patient. When we look at about the high morbidity and mortality of these patients, you can see that the group which is sending the early for the surgery 10 to 20 days after the symptoms of the fever and the starting the treatment of the antibiotics. This group is with the very low mortality next 28 to 24 months. The composite of the embolism, the risk of the embolism is very low in the group with the early surgery when we have this group with the more than 8 embolism of the risk. So when we look at about the embolism, which is the very often with the patients with the infective endocarditis, we must consider early surgical treatment for the large vegetation, highly mobile vegetation, mitral valve localization, and controversial. With risk diminishes significantly over the time with antibiotics treatment. So like when we look at about the guidelines, which is published from the American guidelines from 2014, the class 2A is indication for the early surgery during the initial hospitalization before the completion of the full therapeutic course of the antibiotics is very reasonable for the patients with infective endocarditis who present with the recurrent embolism and persistence of the vegetation despite the appropriated antibiotic therapy. Also, the class 2B is the early surgery with the greater mobile vegetation than 10 millimeters in length with or without clinical evidence of the embolic phenomenon. This is the European guidelines for the prevention of embolism. When we have infective endocarditis of the aortic or mitral valve with persistent. Also, the class 2B is the early surgery with the greater mobile vegetation than 10 millimeters in length with or without clinical evidence of the embolic phenomenon. This is the European guidelines for the prevention of embolism. When we have infective endocarditis of the aortic or mitral valve with persistent vegetation more than 10 millimeters after one or more embolic episodes, despite the appropriate antibiotic therapy, we need organ cardiac surgery and valve replacement. This is the class 1B of the European guidelines. The timing of the surgery for endocarditis after the embolic cardiovascular advance, we could find the embolic stroke when we wait more than 7 to 21 days, hemorrhagic stroke waiting for 4 weeks. If we have the HLH, we can think about the mycotic aneurysm of the brain, avoid the valves that we need anticoagulation. So in 2007, the next appropriated focused valve update guidelines looking about infective endocarditis, they spoke about operation without delay must be considered in patients with infective endocarditis and indication for surgery who have suffered from the stroke but have no evidence of intracranial hemorrhagic and extensive neurological damages. If we have hemodynamically stable, the link valve surgery is for more than 4 weeks may be considered among the patients with infective endocarditis and major ischemic stroke or intracranial hemorrhagic. Complication of endocarditis, which could be identified with echocardiography, we could find very often the abscess of the valvular structures, aneurysm of intravalvular fibrosa, and perforation of the leaflets or the fistula, or the mechanical complication like the secondary to the leaflet destruction, and hemodynamical. Most common cause of the death is irregular lesion with the chronic heart failure. This is the one perivalvular infection phlegmon, which is you can see from the aortic valve. Here is the still moving, and this is the how is looking with the vegetation and this phlegmon, which is patient was sent directly for the cardiac surgery. Valve-related endocarditis is very incidental. Median time from the implantation of the valve, this is around 5 of the months. Risk factors, which we can find more from the young people, male, and moderate to severe aortic regurgitation is very often. Healthcare associated with the organism common with the Enterococcus, Staphylococcus aureus. Survival in the patient with aortic valve replacement transcatheter aortic endocarditis is around 24 months when we find after the endocarditis and have the normal treatment with the antibiotics. Right side in the infective endocarditis is associated mainly with intravenous drug abuse of unwilling catheters or devices. We have the sepsis pulmonary embolism of multifocal cavitation. Most often is connected with the right heart failure, dyspnea of insertion, jugular venous diminishes and lower extremely edema, and perivalvular extension or infection. It is increased with the higher mortality, increased with the high risk of the embolic incidence. This is one clinical case with the 26 young man who is presented with the fever around 38 degrees, started 3 months after implanted pacemaker. He has the high level of the CRP and leukocytes, isolated Staphylococcus aureus from the hemoculture. This is the transthoracic echo. The ejection fraction is actually normal left ventricle function, normal right ventricle function, mild tricuspid regurgitation regarding the implanted pacemaker. This is a transesophageal echocardiography of this patient, and we can look at about this huge mass who is connected to the implanted device on the right atrium of the huge vegetation. 1 month, the patient was sent to cardiac surgery, and 1 month after the explanation of the pacemaker and electrodes, this is the post-surgery transthoracic and
2 minutes left.
transesophageal echo.
Excuse me, ma'am. 2 minutes left. So please wrapping your presentation, please.
Yes. This is one small mass that is without any fever signs from the endocarditis, but after 1 month, the patient has started with another fever, and we sent again for the cardiac surgery. This is the new vegetation. Echocardiography protocol for the right-sided structures. This is unusual that we could find some of the unspecific mass, which is have to see on the right atrium or the right ventricle. Specific morphologic aspect of the right side endocarditis actually is located from the tricuspid valve, Eustachian valve, or pulmonary valves to the cardiac devices also, and even to the right atrial wall can be on the side of the vegetation. Also, as the conclusion of this first part, which is the previous comment of the extent literature of mind, we can put forward the following recommendation regarding the echocardiography of approach on the patient suspecting that they having endocarditis. Echocardiography findings must be assessed with the clinical context. Transesophageal and is very mandatory in the patient with the implanted cardiac devices, or to diagnose the patients with the endocarditis. Then we have this diagnosis is lacking. The Bayesian-based approach should be guided by the decision-making process in the context. As the summary, echo and endocarditis, when we have suspected endocarditis clinically, transthoracic echo is the main that we could perform, but for the diagnosis of the vegetation, the transesophageal echocardiography is mainly for this patient. So the masses we can find in on the ventricle. This is the left ventricle thrombus, very incidence in the current era of the acute myocardial infarction. We can find 5 to 15%. Thrombic occur in the early 24 hours after the acute myocardial infarction. Here is one anterior myocardial infarction with hypokinesic apex of the left ventricle, and one huge thrombus here, which is located toward the zone of the ischemia. And this is the very unusual. This is the thrombus on the right atrium, which is with the high risk again for the pulmonary embolism and systemic embolism. The thrombus of the left atrial appendage is very common, especially with the patients who is with the arterial fibrillation. Transesophageal echocardiography is modality of the choice for the evaluate the left atrial anatomy and function, and meta-analysis of the many of the patients that could be find this is the high risk of the cardiac embolism. Primary cardiac tumors is very rare, less than 1%. They have the high risk of the potential of the embolic potential. We could find myxoma, papillary fibrillostoma. I'm sorry that it's not moving here, the video. Papillary fibrillostoma is strongly associated with the left side mobile PFO and the stalk with the future embolic phenomenon. Transesophageal echocardiography is most accurate to characterize this modality. As last my slide, that take-home message, one echocardiographic modality doesn't fit for all these diagnoses. So the transesophageal echocardiography and other modalities is very useful when we look at about the patients with the endocarditis over the left ventricles or right ventricle masses. Thank you.